So in the fourth section of our lecture, preterm labor, now we will talk about the management of the preterm labor. The important management steps of the preterm labor is the use of beta sympathetomimetics and magnesium sulfate. And then also we can use the drugs like non-steroid anti-inflammatory drugs and calcium channel blockers. And then the use of oxytocin receptor antagonist and antibiotics. So let's start with the management of the preterm labor. First, the use of beta sympathetomimetics. These are the drugs like ritutrine, salbutamol, and terbutaline. These are the drugs also used for asthma, and like salbutamol, terbutaline, these are all used for the asthmatic attack or patient who have asthma. The mechanism of action of beta sympathetomimetics is the production of cyclic adenosine monophosphate. So all these steps, the use of beta sympathetomimetics cause conversion of adenosine triphosphate to cyclic adenosine monophosphate, and this can cause the prevention of the onset of the preterm labor, effective in delaying the delivery or the onset of the labor. Then another medicine or drug that can be used is magnesium sulfate. The magnesium sulfate has effect on the endothelium and it has effect on the smooth muscle. So effect on the endothelium is by the production of nitrous oxide, which cause vasodilation, and it prevent the adherence or sticking of the platelets together by the production of prostaglandins, and it has effect on the smooth muscles also. So effect of magnesium sulfate in 4 steps we have. First, it causes depolarization of the smooth muscle. Then it modulate the uptake of the calcium. Then binding and distribution of calcium in smooth muscle cells occur, and then it causes inhibition of uterine contraction. So main function of magnesium sulfate is the depolarization of a smooth muscle, modulating calcium uptake, and once the calcium uptake is performed by the smooth muscle cells, there is binding and distribution of calcium, and this can lead to decrease in the contraction of the uterine muscle because of the decreased availability of the calcium. Then the effect of non-steroidal anti-inflammatory drugs. We have drugs like ibuprofen. These are the drugs which have reversible, non-specific competitive cyclooxygenase inhibitor. The function of these non-steroidal anti-inflammatory drugs is they have a non-specific competitive cyclooxygenase inhibitor. The effect of non-steroidal anti-inflammatory drug, they inhibit both the physiological stimuli and inflammatory stimuli. They decrease the production of cyclooxygenase 1 and cyclooxygenase 2, and then they decrease the level of prostaglandins. Then they have another prostaglandin E2, prostaglandin I2, and TXA2, and similarly all these are the factors which are responsible for the contraction of the uterus. So cyclooxygenase inhibitor, as a result of reversible non-specific competitive cyclooxygenase inhibitor, they decrease the level of cyclooxygenase 1, cyclooxygenase 2, and decrease the production of prostaglandins, proteases, which cause decrease in the contraction effect, and there is no contraction, there is no onset of the labor. So non-steroidal anti-inflammatory drugs are also very helpful in this regard, like indomethacin. Then calcium channel blockers. Calcium channel blockers are the drugs used for hypertension. We have verapamil, nifedipine, diltiazem. All these are the drugs used for high blood pressure. They block the calcium excess. Since they are calcium channel blockers, they block the availability of calcium, decreases the level of calcium, and decrease the contraction and conductivity of the heart. So contraction, if this is decreased, then it can cause bradycardia, headache, abdominal discomfort, peripheral edema, but again it can decrease the contraction of the uterus because of the decreased availability of the calcium. And these drugs are also very commonly used for hypertensive patients. Oxytocin receptor antagonist, we already mentioned oxytocin is the hormone that causes contraction of the uterus at the time of the onset of the labor. So anything that can decrease the level of oxytocin, or any oxytocin receptor antagonist can decrease the level of oxytocin and decrease the contraction of the uterus, like atosiban is the oxytocin antagonist. It causes it's competitive antagonist of oxytocin and vasopressin, binding to both the oxytocin receptors and the vasopressin receptors causes decrease in the availability of vasopressin and oxytocin and leads to the prevention of the contraction of the myometrium. Then corticosteroid therapy, corticosteroids like betamethasone or dexamethasone, they lead to fetal lung maturation, fetal growth, organ system maturation, fetal brain development, immune function, and hypothalamic hypopituitary axis. So use of steroids like betamethasone and dexamethasone, especially if the labor is preterm, is helpful in the maturation of the infant by maturing the lungs and different organs and the brain of the fetus. Antibiotics really don't have any effect. They are not effective in the prevention of the onset of preterm labor. Management of premature rupture of membranes. Premature rupture of membrane is serious and usually leads to the onset of labor before 37 weeks. Rupture of membrane can occur in any trimester of pregnancy. What happens with the rupture of the membrane? pregnant women should know that if the membranes are ruptured, though, so they can have the proper management. So with the rupture of the membrane, there is gush of watery fluid from the vagina. There is persistent sense of fluid leaking. There is leakage of fluid or wetness of the underwear. There is watery blood-tinged discharge, low amniotic fluid on ultrasound, and the statistics is 40% of premature birth are due to rupture of membrane. 31 years usually average maternal age at rupture of membrane. 34 weeks standard induction of patients is stable. Usually if 34 weeks gestation is there and rupture of membrane occurs, then the induction of labor should be done. At 24 weeks, gestational age of fetus viability in US. 54% rate of vaginal birth following premature rupture of membrane. 93% is affected mothers are non-smokers. 55% cases have no known cause. These are some statistics. If the rupture of membrane occurs at different periods of gestation, and if the fetus is at the reaches the age of viability, then induction of delivery is recommended. And then rupture of membrane is an emergency. Make sure to contact the doctor immediately, telling them your concerns, that your patient thinks that there is rupture of the membrane and there is leakage of the fluid. So that was all about the management of the preterm labor. Thank you for watching sqadia.com.